The next speaker for the day is Dr. Hernando Garzon. So let me introduce him to all of you. Dr. Hernando, MD, is board certified in emergency medicine and has practiced with Kaiser Permanente since 1992. His 14 domestic disaster response deployments have been with the FEMA Urban Search and Rescue System and have included in the Oklahoma City bombing, the World Trade Center during the terrorist attacks, New Orleans during Hurricane Katrina, and others. His 8 international disaster responses have been with multiple humanitarian relief organizations and have included the Southeast Asia tsunami in Sri Lanka, the Kashmir earthquake in Pakistan, civil unrest situations in Kenya and Nigeria, the Haiti earthquake, and most recently the drought in Somalia and Kenya. Dr. Garzon serves as the director for Kaiser Permanente's Global Health Program, and in this role has helped to develop in the capacity of building and sustainable volunteer clinical programs in Kenya, Zambia, Vietnam, Cambodia, and other countries for the clinical staff and residents of Kaiser Permanente. He also serves on the board of directors of for Relief International and actively participates in their emergency response and capacity building medical programs. So I would now like to invite Dr. Hernando to do his presentation on the topic, the beginning role of paramedics in trauma. Over to you, sir.
Thank you very much, and thank you very much for the opportunity to be here and to speak with you and share some information. I'll see what I can do to get you out for tea time by 3 o'clock, and I will. I'll talk about that. So I've been asked to speak as a nice complement to the lectures that you've already heard by Ms. Renee and Dr. Leonard to the trauma care. I've been asked to speak about the role of trauma or the role of paramedics have in trauma care. And I think to do that, I want to give you an overview of EMS systems and the different kinds of systems that can exist in high resource versus low resource countries. So this is an overview of what I want to speak with you about today. I'll give you an overview of emergency medical service systems around the world, and then I'll speak a little bit about EMS systems in Sri Lanka, and I believe we'll hear about that a little bit more tomorrow, so I'll be brief on those comments. I'll also speak about the key elements of trauma care in the pre-hospital setting, and then talk about some recent advances in trauma care that are relevant to Sri Lanka in this kind of setting. And then, as I mentioned, I think it's important to think about creating a realistic pre-hospital care system and understanding the resources that you have here in Sri Lanka. You can accommodate or adapt to the resources that are available in larger cities versus rural settings. So in general, there's sort of 2 models of EMS systems around the world. The first is called the Franco-German model, and this is more of a stay and stabilize philosophy. The idea is to bring the hospital out to the patient. These systems frequently have physicians on board on the ambulances. And you can see on the slide a number of the countries that use that model: Germany, France, Greece, and so on. This is a very resource-intensive system because you have to have a high level of care out to the field, not just with equipment, but with personnel. To put physicians on every ambulance is really not possible for a community that doesn't have even enough physicians to put in the clinics to do the average care for patients. The other model that is more effective and more appropriate for a lower resource setting is also actually used very frequently in developed countries, the Anglo-American model. That's more of a scoop and run philosophy. The idea is to bring the patient to the hospital and to definitive care as quickly as possible. And in this system, you can staff your pre-hospital care system, ambulances, or whatever other transport vehicle you have with EMTs or emergency medical technicians and paramedics. So I'll go through and define those in a little bit. But the countries that use the Anglo-American model are the UK, the United States, Canada, and now recently Sri Lanka. And so as I mentioned, I think it's important to make a distinction between a high-resource EMS system and a low-resource EMS system. The picture on the right, on the left, with all the firefighter paramedics there is a typical scene in the United States. We have developed EMS systems all around the country in rural as well as urban settings. And you can see for this one traffic accident, I tried to count the number of personnel on there. There's probably 12, maybe 15 specialized firefighters, paramedics that responded on scene to a single emergency. You have a fire truck in the background. You have an ambulance on scene. Clearly this person or people are getting adequate care in the field, and these people are well trained. In a low resource or no resource EMS system, you have more the picture that you might see on the right. And after listening to Ms. Renee's and Dr. Leonard's lectures, I have to wonder, if you look at the picture on the right, do you think that person's airway has been assessed, or that someone is protecting his cervical spine, or giving him spinal immobilization as needed? Has anyone checked his pulse to see if he even has circulation? So even the way that this patient is being carried, you get a sense that while these bystanders are very well intentioned and want to help the person that's been injured, there's no level of training there that's helping them help the patient adequately. You don't even know if the bleeding has been evaluated or considered. As Dr. Leonard said, bleeding is the most common preventable cause of death after the traumatic injury. And there's no evidence on the right that they've done anything to evaluate that or assess that. So what can we do when we have the situation on the right, a low resource setting, to make a difference for patient care in the pre-hospital setting? And I'll talk about that. So a little bit on trauma in Sri Lanka. This data I gathered, you can see on the bottom, from the Ministry of Health website, the Trauma Secretariat website. It's the leading cause of hospitalization in the country. It accounts for over 600,000 patient visits per year to government hospitals alone. Most of the moderate and severe trauma results from road traffic crashes, or as we say in the United States, we call them motor vehicle accidents, MVAs. And significantly, the number of crashes has increased by 250% between 1977 to 2004, and the fatalities have increased about 160%. And I'm sure that's for many reasons: higher population, more miles driven, those kinds of things. But one of the other things is probably better roads. And I was having a conversation earlier who said, in an urban setting where you have a lot of traffic congestion or bad roads and your cars aren't going more than, say, 40 kilometers an hour, the accidents tend to be lower speed, more survivable kinds of injuries. But as you improve road conditions and you have freeways that now cars are traveling at 80, 100 kilometers an hour, that results in higher fatalities and more injuries. And then in Sri Lanka, the road traffic deaths, there's one every 4.5 hours on average. That's 6 today. So the Trauma Secretariat is a subdivision or subsection of the Ministry of Health that came into existence after the tsunami in 2004. And the Trauma Secretariat is responsible at a government level for all of the things that you see here on the slide: pre-hospital care, injury surveillance, training, developing clinical protocols for trauma care, and all the different trauma system components that are in place. As I mentioned, it came into existence in 2004 after the tsunami. There have been other really wonderful developments. When I looked to prepare this lecture, I was trying to get information about the resources that are available and what's been developed or what's in existence here in Sri Lanka. And it's interesting that at least in 2009, became the establishment of a 3-digit emergency access number, 110. So in the United States, we use a 911. So you call 911 from any phone in the United States, and you will get an emergency dispatcher who asks you what's the nature of your emergency. And if it's a crime, they will dispatch law enforcement. If it's a fire, they dispatch the fire department. If it's a medical problem, they'll dispatch the EMS system, which is usually with a fire department. So we have a very developed 3-digit emergency access all over the country. Here in Sri Lanka, that's been come into use in 4 cities: Colombo, you can see here on the list, right? Galle, Kandy, and Jaffna. And these 4 cities, I was looking, really only cover a population of just over 1 million. So still the majority of the country does not have an emergency access phone number that they can easily call to access emergency medical services. In addition, this process of developing a pre-hospital care system has resulted in the development of education and training for emergency medical technicians and paramedics. And there's an organization that's a private organization that's the first certified training institution to provide certification and training at an internationally recognized standard of care. And so I want to go through the differences or distinctions between the different levels of EMTs and what we call paramedics. And this is also from the Sri Lanka website information. So this is how Sri Lanka is distinguishing the different levels of emergency medical technicians. There's levels 1 through 4. So level 1 here is really just above basic first aid. And the idea here is to train really mostly first responders like firefighters, police officers, lifeguards, coaches, teachers to be trained at an EMT 1 level. And they're trained in basic rescue, oxygen use, CPR, splinting, and safe ambulance operations. So that's really the lowest level of person with at least some basic training that can help assist and be a good first responder and perhaps operate in an ambulance. The level 2 EMT is referred to as an EMT basic, and this is the level of EMT that I'm used to from the United States. We train EMTs, basic EMTs, to do all of the things that you see listed at the bottom of the slide. And I put here in bold print that this is really the minimum level of appropriate EMT training to provide adequate trauma care. And I'll explain why later on here. But as you can see, that the bullet points of the training that EMTs get at this level, level 2, is the exact things that Dr. Leonard and Ms. Renee talked about in terms of the ABC sequence and the ATLS care of patients, right? Airway management, spinal injury, assessing and immobilizing spinal injuries, assessing vital signs, all those things that come into play in the ABCDE algorithm of advanced trauma life support is at this level, EMT2. And here in Sri Lanka, that requires 120 to 160 hours of training. That's really about a month course. In the United States, most EMT training programs are 3 months. Then there's also EMT3 and EMT4. EMT3 is also called in other countries, we call it in the United States, an EMT Intermediate. And the difference between an EMT Basic and an EMT Intermediate, largely, is that EMT Intermediates or EMT Level 3s can establish IVs and give certain medications. And then finally, there's an EMT4 level, and while there's not current training for that in Sri Lanka, it appears that that's eventually the goal to reach here. And EMT4s, or level 4, are what we would consider in the United States paramedics. So we distinguish between an EMT. When we say EMT, we're talking about an EMT basic or level 2, and then a paramedic, which is more like this EMT level 4, that has more training. In the United States, a paramedic training class is usually about a year, and then with 6 months of field proctorship and working on an ambulance and everything. So it's a longer training sequence. In addition, the ministry has also developed, in coordination with a United States non-governmental organization, Medical Teams International, they essentially took existing international training standards for EMTs and translated it into Sinhalese and Tamil. And so this book, I think, is available as of 1 or 2 years ago and is available for training here in Sri Lanka. And this book trains to level 1 and 2s. It does not train level 3s or 4s. So let me move on and talk about pre-hospital care, trauma care in the pre-hospital setting. And I'll specifically talk about what we do and what you're doing here in Sri Lanka, which is the Anglo-American system. As I said, that's really a scoop and run philosophy. And as I mentioned before, I think one of the takeaway points that you should get is that this is largely an EMT level of care. So in a way, the title of my lecture, The Role of the Paramedic in Trauma Care, is a bit of a misnomer, that really, even in a sophisticated EMS system like the United Kingdom or the United States, trauma care can be very efficiently done by somebody at an EMT 2 level or a basic EMT. So our job in the scoop and run philosophy for trauma care is threefold. Get to the patient quickly, fix what you can fix in the field quickly, and then quickly get the patient to the right hospital. And again, the idea behind that is the best survivability comes from controlling hemorrhage and getting definitive surgical care as quickly as possible. And so I put in parentheses the average times for these 3 stages, response time, on-scene time, and transport time, that we have in the U.S. And this is the model. So get to the patient quickly. I put 4.5 minutes. That's the average time from when dispatch gets the phone call till the ambulance is next to the patient in Sacramento County. And our national average is around 5 minutes. So just to give you an example, for frame of reference, Sacramento is a city about 550,000, I think 600,000. It's about 500,000 people. Right? Colombo is like close to 800,000 or something. I have 4 fire departments and over 100 ambulances and 600 paramedics in that system. So we can provide care very quickly. Our firehouses and ambulances are spread throughout the city. So, what usually will happen is an accident happens on the road really within seconds. Usually within 30 seconds, a bystander is on their cell phone calling 911. They call 911. The dispatcher starts to take the call, says, what's the nature of your injury, traffic accident, are there injuries? Before she's done or he's done with the conversation, that dispatcher has pressed a button and is dispatching an ambulance. And you already have paramedics and firefighters getting in their ambulance, taking off to the scene. Across their computer comes the address of the reported accident, and just that it's a car accident. As the dispatcher gets more information, how many victims are there, what are there, those kinds of things, that dispatcher will then push that information to the paramedics and firefighters that are already en route. And that's how we get a 4.5-minute response time from the time the call is placed. They get there, and again, we're in a scoop and run system. So the fix what you can, the paramedics will walk through exactly what you heard Dr. Leonard and Ms. Renee talk about. They will deliver advanced trauma life support. They do the ABCDEs. They make their interventions. They splint what they can. They do airway support. They get the person on the gurney, and they're off to the hospital. Our average scene time is less than 10 minutes. It's not just an average. It's actually an expectation. And then the transport time to the hospital, because we now have 3 main trauma centers in Sacramento County, is usually less than 7 minutes. So if you add that all up, from the time of the accident happened to the time that the medics are delivering the patient to the surgeon, it's less than 20 minutes. And that, despite all the other care that we can deliver in the field, I think one of the greatest successes of an advanced EMS system is that we can shorten that time to definitive care to less than 20 minutes. And frequently, our hospitals are set up in the same model. So the other thing that's really critical here is that our medics and our EMS system calls the hospital en route to say, I have a trauma coming, and they give the details. And the person who takes the call activates the trauma team, and the surgeon will come down and is waiting in the emergency department to receive the patient. So frequently, if you think these are good response times, in our trauma centers, after the patient rolls in the door, they go through everything that Ms. Renee spoke about in the hospital. And if that patient needs surgery, they're frequently up in the operating room within 10 minutes frequently. So they're already getting their surgery, life-saving surgery within 30 minutes of the time the accident happened. One of the reasons why trauma care in the pre-hospital setting is at the EMT basic level is because it's very, what we say is cookbook. Like there's not a lot of decision making or not a lot of judgment that goes into the process. It's very protocol driven, and it's if you see this, you do that. If you see this, you do that. And so their steps are fairly straightforward, and you can walk through them very quickly, and it doesn't take a lot of sophistication to deliver the stabilization and the transport that's necessary. The one thing that I would add to the ATLS ABCD algorithm that's been discussed already is in the pre-hospital setting, as a rescuer, as a first responder, the very first thing you worry about is scene awareness and scene safety. So before you deliver medical care, paramedics and rescuers are trained, one of the first rules of being a rescuer is don't become a victim. So if you're in the middle of the road with traffic flying by you, someone has to sort of be stopping traffic and diverting it around you. Or if you see a victim that's lying in a pool of a liquid that turns out to be gasoline from a ruptured tank or something, and there's a fire burning in the car, don't go and start delivering care and start doing your ABCs, because what if that gasoline catches on fire with you and the victim? So you take the victim, stabilize his neck, drag him out of the gasoline, and then you can start doing your care. So for first responders and rescuers, scene awareness and scene safety comes before anything else. Don't become a victim, and then you can deliver your care, your ATLS care and your ABCs. So I just want to go through as an example the Sacramento, our trauma care policy, and as I mentioned in the Sri Lankan system, policies and protocols are being made. Any EMS system needs to have these kinds of policies. And there's just a couple of things that I want to highlight, and I'm not sure you can, I don't expect you to read this. I'm sure you can't read it from the back, but you'll go down and see. So 2 points. Almost all of our protocols are divided between BLS care and ALS care. You can see sort of halfway down on the page, it starts to be 2 columns, and then on the left you see BLS. BLS is basic life support. Those are the interventions that EMT basics or EMT level 2 can make. On the right side, you have ALS care, advanced life support, and those are the interventions that the paramedics or EMT level 4s can make. So just under the trauma in that box there, you probably can't read it, but one thing I want to emphasize is that our protocol says time on scene should not exceed 10 minutes under normal circumstances. Conditions requiring that more than 10 minutes scene time must be documented. So in other words, it's our expectation that if you're responding to trauma, you spend no more than 10 minutes on scene. It's a way to emphasize the importance of getting the patient to definitive care in the hospital quickly. If they need to spend more time, they need to tell us why they did so. And there are legitimate reasons sometimes, but they have to be documented. So also, as I go down this protocol quickly, it's divided between the BLS and ALS, but it also goes through an ABC DE kind of format here. So the first thing you can see for the BLS side is oxygen and airflow. On the right side, paramedics can do airway interventions like intubations if it's necessary. The other thing I want to, and then the next thing down on the ALS side, and this is about, other than an advanced airway, this is the only other thing in our protocol that is a paramedic level intervention, and that is using needle thoracostomy to decompress a tension pneumothorax, as you saw the slide before. That's an ALS intervention. But otherwise, the care here is all BLS. So as I continue down this protocol, you can see that it's all on the BLS side of the equation. A paramedic can do it, of course. You have to understand that, right? But we're talking about this. The level of intervention in terms of the training required is really just BLS. So, for example, we talk about amputations. How do you manage that situation? What do you do with the parts? We talk about evisceration of the abdomen, about flail chest. Hemorrhage control. First method of controlling is direct pressure. If unable to control, CR hemorrhage policy, and I'll talk about that later. Impaled objects, open chest wounds. It's all BLS interventions. Down here, splinting on the BLS side. We do have, is not life-saving, but it's humane. On the right side, we have instructions to do pain management for traumatized patients can get morphine in the field, or we're using fentanyl as well. And then on the BLS side, we talk about eye injuries and head trauma, and then they're off into the hospital. So the two things to emphasize about this is short scene time, and it's 90-95% is BLS intervention. There's very little ALS intervention in appropriate trauma care in the field. So I want to talk about a couple of recent advances in trauma care that I think are changing the way we practice in the United States, and I think can be very helpful and effective in a community such as Sri Lanka. And really all of these advances are around hemorrhage control because, again, hemorrhage is the #1 preventable cause of death after an injury. So that's tourniquet use, blood stoppers, and tranexamic acid. A lot of this information comes from a recent war experience. And again, I don't expect you to read this, but this is our Sacramento Hemorrhage Policy. And it really goes through basically how you control hemorrhage. The first thing, of course, always is direct pressure to a wound and dressing the wound. Frequently, though, with arterial bleeding, that's not enough. And so this algorithm goes through how and where you can use tourniquets. Tourniquets were in vogue decades ago, but fell out of fashion for a number of reasons. Some people didn't think they were effective. There was also issues of tourniquets causing limb ischemia or nerve damage and neuropraxias from compression on nerves. So they really fell out of favor. But military experience over the last 5 to 10 years has shown that they can actually be used very safely, and they've developed sort of more sophisticated tourniquets. If you don't have anything else, people have used ties, people have used their belts. Those kinds of tourniquets can be effective, but they're not always effective, and they cause a higher rate of complications like the neuropraxias and things like that. The image on the left shows one of the available commercial tourniquets. It's called a CAT, Combat Application Tourniquet. As I mentioned, most of these things in the last 10 to 15 years have been developed through military experience. There are many options. There are probably a dozen different kinds of tourniquets out there. In general, they tend to be broad, not a thinner string. That's less likely to cause tissue damage. Again, they're inexpensive. They're easy for first responders to carry. And within certain limitations and protocols, they're great to control arterial extremity bleeding. And that's something that I would recommend should be in any trauma care EMS system, even a low-resource system that just has basic EMT level skills. The other thing I want to mention briefly are what's a pool of chemicals or compounds known as blood stoppers. And I just mention it because I think it's important to know in case you read about these things. I don't think it's something that's useful for this kind of system. Many of these also have been developed through military experience in the last 10 to 12 years, 10 to 15 years. They tend to be expensive. There are a number of compounds that promote clot formation. They're best to use where you have large areas, like in blast injuries, a lot of the images that you saw in the last presentation. If there was active, ongoing, continuous bleeding, lots of venous bleeding from multiple sites, that's very difficult to pack and control. You can use these blood stopper compounds. Some of them are powders that you pour in the wound. Some of them are impregnated in gauze, and you lay the wound with the gauze, and then you dress over it, and you can put pressure. They have some side effects. Certain ones of these, when they got wet and reacted with the compound, caused a hyperthermic reaction, so they generated heat. If you dress that wound, you can create thermal injury to the tissue. So it's more complex using them. It's not clear that they have a benefit in an urban environment where you mostly see broken limbs, car accidents, and you don't tend to see the war type or blast injuries that you saw in the last presentation. The other thing is that they're quite expensive, $40 or $50 a use, and it's unlikely that that's going to be cost effective in an EMS system in a low resource setting. The other thing I do want to mention, I think does have tremendous application. We've started to see some use of this in the United States, but I think it has tremendous benefit for middle and low resource setting. Tranexamic acid is an antifibrinolytic agent, so it prevents it prevents the fibrinolysis that happens and promotes clotting. It's easy to administer IV, so you have to be an EMT Intermediate or level 3 who can start IVs, or a paramedic to do that. But it's inexpensive and it has few side effects. And I want to quote a couple of recent studies. There's a CRASH 1 followed by a CRASH 2 study. The CRASH 2 study was published in The Lancet in 2010, and it involved 20,000 patients in 40 countries, 274 different investigation sites. Most of these countries were middle and low income. And really the findings are fairly astounding. There was a 32% reduction in mortality if the tranexamic acid was given within 1 hour, and actually it showed benefit giving it up to 3 hours. It improved survival through mostly mild and moderate bleeding. For patients who had arterial severe bleeding, this is not effective. This is when you need direct pressure or tourniquets. Very interestingly, the World Health Organization has added this medicine to the list of essential medicines. So basically they're promoting this and endorsing this, and they're saying this should be part of the national formulary in every country. A follow-up study on the same patient pool, the same 20,000 patients in the CRASH 2 study, was published in 2011, just a year later. And the goal behind this study was to look at the data of the CRASH 2 study of those patients and say, well, is this cost effective to use in low and middle income countries? And you can read the details of the findings here, but the conclusion at the bottom of this slide, you can see early administration of tranexamic acid in bleeding trauma patients is likely to be highly cost effective in low and middle income country settings. So if you look at the numbers here, basically, when they looked in giving this in India, it cost an average of $17 per patient to give. In Tanzania, it cost $19 per patient to give. If you consider the 32% reduction in mortality, that is so many lives saved. And in terms of, I mean, really, you have a 30-year-old father of 3 who, you know, if you can save that life, think of the years of life saved in terms of livelihood and those kinds of things. So very relatively inexpensive medication and very high likelihood of incurring benefit. And just a map of where the CRASH 2 studies were done. You can see the little red stars were the 40 countries that were involved. Sri Lanka is on that list, so somebody here knows about tranexamic acid. And hopefully it's in the protocols for the pre-hospital care system here. So let me go back and wrap up and talk a little bit about trauma in low-resource countries, because it's great when you have resources like the U.S. or the U.K. or Australia, and you can put lots of ambulances out there and train lots of paramedics and make sure you have those 20-minute response times. But what if you don't? What if this is the current state of pre-hospital care in your community, in your town, in a rural area? I think it's wonderful to see that in the larger cities here in Sri Lanka, there's an EMS system, there's ambulances, there's training for that kind of stuff. I think in the cities, you can hope for a higher level of response or sophistication of the EMS system. But I think that probably in rural areas or small villages, we're very far away from achieving that 12 paramedics on scene picture that you saw in the U.S. And you're really looking at how can we deliver effective trauma care in a low-resource setting effectively. So the thing to realize about this, if you listen to the care that you need to provide in the field, and you realize, as I mentioned, that what you need is a low level of basic EMT skill to get the patient to the hospital quickly, that at least is a start. And we can do better than what you see on this slide, where you have essentially 4 very well-meaning bystanders not knowing really what they're doing in terms of delivering medical care. So there's a precedent for this, and I was involved with some of this early work and research in Nigeria in 2010. I did a response with Doctors Without Borders, and there is increasing escalation of civil violence in Nigeria at the time, and I went to Jos, Nigeria, to specifically evaluate their trauma care systems and make recommendations to the healthcare system. And this article, published in 2012, is very similar to the conclusions we drew. And if you know what's going on in Nigeria now with all the violence and all that, these communities like that, anything can happen anytime. And whatever you can do to increase your trauma care system in the pre-hospital setting would be helpful. So this was published in the Pre-Hospital Emergency Care in 2012. And the title is Assessment of the Status of Pre-Hospital Care in 13 low and middle income countries. And you can see the conclusions here. I bolded the important things here. So conclusions: make use of an already existing network of first responders, such as commercial drivers and laypersons. More widespread first aid training and better encompassing their efforts within a formal EMS system are warranted. And what we discovered, what we suggested in Nigeria that clearly didn't have the resources to stand up an EMS system that included a 3-digit emergency access number with everybody and well-staffed ambulances and trained paramedics, we realized that for relatively little cost, who are the people who already respond in trauma, right? They're bystanders and citizens who want to do the right thing. They're who gets people to the hospital. They put them in a taxi or put them in a private car. So the model that we came up with and other people have pioneered in other places is again, it's a multidisciplinary approach, as Ms. Renee was talking about. You really have to involve your community services, community organizations like the Red Cross or other or civic organizations. your medical system, but why not create a system where you can train your bus drivers, your cab drivers, your anyone who works in stores or in markets and things like that. You can train them at an EMT 1 or EMT 2 level. You can give them a supply, a backpack of basic first aid equipment that they can keep in the trunk of their car or keep in their scooter or keep in their shop. So that's available to use. And then you tie something to it. Like if you can inventory the equipment and make sure they haven't used it for their own purposes, and once a month you give them a tank of gas, or you give them some food, you give them some nominal payment for being involved with the program, and then if they do respond, if they do bring in a victim, there's some pay for them that comes from the health system. So again, all of these things need to be very specific and tailored to the community that you're in, the organizations that you're working with, but you can come up with very creative ideas to train people who are already there, people who are out in the community, get it organized and coordinated by civic-minded organizations in coordination with the healthcare system and the government system in your communities. And for relatively little cost, you can train up community people to be basic EMTs, and you can have a process to get them to deliver them to definitive healthcare very quickly. So that's a very brief presentation, but you don't need to look at an EMS system like we have in the United States or in the UK or in Australia. You can do something very basic and very low cost and actually save a tremendous number of lives in terms of trauma care. Tea time.